But excessive bleeding might be spotted as bruising, possible hematuria. What drugs could cause excessive bleeding? Well, the drugs that reduce the ability of the blood to coagulate, anticoagulants, such as heparin or warfarin. So if a patient's bleeding, it's worth considering whether they're on anticoagulants or not. Bradycardia. The heart rate is slow. The patient may not be able to maintain an adequate blood pressure. This could be a side effect of drugs such as beta blockers or digoxin, for example. Low blood pressure, possible postural hypertension, feeling dizzy when the patient stands up. Well, this can be caused by diuretics, by beta blockers. It can also be caused by the ACE inhibitors, the angiotensin converting enzyme inhibitors. In fact, any hypotensive agent can, I think, clearly give rise to hypotension. A lack of respiratory effort. Well, respiratory depression is the classic side effects of opium-based drugs such as morphine and diamorphine. Constipation. What drugs can cause constipation? Well, opiates can cause this, but maybe things containing codeine, such as codeine phosphate or dihydrocodeine, are the classic examples of drugs causing constipation, which can be very severe. Depression of the bone marrow, giving rise to immunosuppression and immunocompromise. Well, this can be a consequence of treatment with antibiotics, especially chloramphenicol. Sometimes long-term antibiotics can cause this. It's uncommon, but it is reasonably common with chloramphenicol. For this reason, chloramphenicol should really be kept as a last resort antibiotic. Cytotoxic drugs can also cause bone marrow depression, and any drugs that inhibit the activity of folic acid can do the same. Excessive sedation, a drowsy patient. Well, again, this can be caused by any drug which we give as a hypnotic. A hypnotic is a drug which induces sleep, such as benzodiazepines, such as barbiturates. Parkinson's features such as rigidity and tremor. Well, these can be caused by the antipsychotic drugs such as chlorpromazine, a member of the phenothiazine group, and other drugs such as haloperidol. So when a patient presents with clinical features and that patient is on some drug or other, consider whether the clinical feature could be caused by the drug the patient is being given. Now, for the final part of this general introduction to principles of pharmacology, I want to talk about giving drugs to older people. Now, it's very important in older people to avoid polypharmacy. This means giving many drugs. So typically you give one drug, then you give another drug for the side effects of the other drug, and the patient ends up on 2 or 3 drugs. That should be avoided because drugs should only be given when there's a specific clinical indication. Now, sometimes the absorption of a drug is delayed in elderly people. Indeed, in any person, if there's antacids containing magnesium, calcium, aluminium ions, these ions can form insoluble complexes with other drugs in the stomach, in the gut, and prevent the absorption of other drugs. So sometimes the effect of the drug might not be working because the absorption has been slowed down by another drug, particularly antacids. And in the elderly especially, there can be reduced amounts of hydrochloric acid in the gut and reduced gastric perfusion, both of which can lower the rate at which a drug is absorbed. Now, we have previously talked about the concept of protein binding, the fact that drugs bind to protein, albumin mostly, in the plasma. When the drug is bound to the albumin, it's not free. When it's not free, it doesn't have its pharmacological effect. So free fractions of drug may have therapeutic or indeed toxic effects. Protein-bound drug is inactive. But in the elderly, albumin production declines with age. So there's less albumin in the blood, that is, there's less protein in the blood. So for a given dose of drug, less of that given dose will be protein bound. That means there is more free drug in the plasma to enhance the pharmacological effect. So a given dose of drug in the elderly may have a greater pharmacological effect than the same dose of drug in a younger person, even though they're both the same weight, because the older person has less albumin, therefore there is less protein binding. If there's less protein binding, there's more free drug, therefore there is a greater pharmacological effect, which may be therapeutic or toxic. And drugs which bind, well, most drugs actually protein bind to some degree, but drugs which are well known for their high affinity to the protein and having a lot of protein binding, therefore may give rise to greater pharmacological effects in the elderly, particularly include phenytoin, aspirin, tolbutamide, naproxen and warfarin. So the elderly may well need smaller doses of those drugs, and indeed to some degree all drugs, than younger people would need. Now, another reason drugs may have enhanced pharmacological activity in the elderly as opposed to younger people, in addition to protein binding, is there may be a lowered rate of metabolism of the drug in the liver. Because with age, hepatic circulation and function decrease. If there's less liver function, less hepatic function, the liver is less able to break up the drugs, at least not as able to break down the drugs as quickly. That means more drug is left in the circulation, more drug for longer. That means that there's an enhanced pharmacological effect. So reduced liver function and circulation is one factor. So this means that drugs normally catabolized, normally broken down in the liver, will have a longer half-life than would be the case in younger people. This is true of benzodiazepines, for example. This is why old people can sometimes be drowsy if they take benzodiazepines for a long periods of time, because the liver is having difficulty breaking the drug up. Now, there's also an effect on first-pass metabolism. Now, first-pass metabolism is the breaking down of a drug the first time the drug passes through the liver in the circulatory system. So remember that when drugs are absorbed from the gut, as with the products of digestion, the drug is absorbed into the hepatic portal vein. The hepatic portal vein takes blood directly from the gut to the liver. This means that the drug arrives in the liver in fairly high concentrations and is broken down. Now, some drugs, again such as beta blockers, are broken down quite a lot by first-pass metabolism. Other drugs are broken down less by first-pass metabolism. But if the liver is not metabolizing as effectively in an older person as in a younger person, there will be a decreased first-pass metabolism effect. Now, a further reason drugs can have an enhanced pharmacological effect in the elderly is because of reduced renal function, reduced function of the kidneys. Now, when most people are born, they have about 15 times more renal capacity than they actually need. This is why someone can lose a kidney and still have perfectly normal abilities in terms of being able to excrete waste products and water. Even into older adult life, very often we have a lot of reserve renal capacity. But in some older people, renal function does decline to the point where they are no longer able to excrete drugs normally through the kidneys, and this can result in accumulation of the drug. Indeed, this is true in any patient who has impaired renal function, that the drug will not be excreted as efficiently, therefore will be retained in the body for longer periods of time. And just to take one example, Amino glucoside antibiotics. Now, these are things that contain the term mycin. For example, you might have come across gentamicin. So these antibiotics with mycin in the name rely on the kidneys for excretion. And these drugs are highly nephrotoxic. That means they can damage the kidney, and they're also ototoxic. That means they can damage the ear and hearing. So it's important to adjust the dose of these antibiotics if there is any impairment in renal function. And even if there's normal renal function, we like to check the dose of these antibiotics because the risk of renal failure and deafness is a real one. So bear in mind, reduced renal function may mean that a drug is retained in the blood for longer. Now, the last point I want to make about drugs in the elderly is related to end organ pharmacodynamics. End organ is the organ that you want the drug to have an effect on. It's the way the drug is used in those organs. And that can sometimes differ with an older organ compared to a younger organ. For example, older people have increased sensitivity to anticholinergics and are more sensitive to benzodiazepines. Well, that's the end of this talk on introductory pharmacology. Quite a frustrating subject to teach, really, because there's so many specific things I haven't told you. In fact, I haven't really told you any specific things. We've just tried to cover general principles. But it's very important that you try and take these general principles and relate them to your particular area of practice. Learn all you can about the drugs you're using. Learn their indications, contraindications, side effects, special precautions, doses, particular risk of adverse reactions. You must know the drugs that you are giving. Combine that with getting a knowledge of the disease states that you are treating. Try and work out how the drug interacts with the disease state to bring about a therapeutic effect. Try and gain information about your patients as individuals, so you can relate the information in your mind about the drug, the information in your mind about the disease state, and relate that to an individual's position, an individual's situation. Because the aim, of course, is to help individuals. Well, we're going to carry on the theme of this video now by looking at injections. We've looked at basic principles of pharmacology. Now we'll look at injections, a particular way of administering drugs. Interesting, injections have actually been around since about 1860, so it's something that nurses have done for quite a long period of time. Now, we mentioned that drugs can be given enterally, which is via the gastrointestinal tract, and drugs can also be given parenterally, which is another way other than via the gastrointestinal tract. And the common ways that drugs are given parenterally are intravenously, intramuscularly, and subcutaneously. They're the common ones, which we're going to have a look at on this talk. Now, let's think first of all about why we might give injections. What are the indications? Well, mostly, of course, it's to give a drug to bring about improvement or cure in the patient's condition. But they can also be used sometimes to aid diagnosis. Some drugs are given to help with a diagnosis. Less common. Most commonly, it's for therapeutic reasons. And when you give a drug parenterally, you get higher plasma concentrations more quickly. We've actually seen this on the previous video, but intravenous concentrations will rise very quickly if the drug's given intravenously. Intramuscularly, it'll rise fairly quickly. Subcutaneously, it'll be a bit slower. So you can get fairly high concentrations fairly quickly by giving injections. Now, some drugs, for example insulin, if they're taken orally, would be broken down by the digestive enzymes in the stomach. Now, why is it that insulin is broken down by digestive enzymes in the stomach? Well, the reason is that insulin is a protein, and in the stomach you have enzymes that break down proteins. Digestive enzymes and hydrochloric acid help to break down proteins in the stomach. So if you gave insulin tablets, they'd simply be broken down into amino acids and would be of no good to us whatsoever. So we have to give it by injection to bypass the gastrointestinal tract. And some drugs can't be absorbed through the stomach. For example, vitamin B12, hydrocobalamin, cytamine injections have to be given by injection because if you give them orally to certain patients, they can't absorb them. Most people can absorb it orally, of course, but some patients can't, so it needs to be given by injection. Other people might be unable to take oral medication because they're nil by mouth prior to surgery, so it's a very good way to give pre-medication. Maybe they're unconscious, maybe they're in a coma. For example, sometimes we give glucagon to patients that are in a hypoglycemic coma. Give them an injection of glucagon. That can sometimes be enough to wake them up when you can give them a drink of glucose or something to bring the blood sugar back up to normal. Now, a lot of people have an enhanced placebo effect when they get an injection. Now, the placebo effect is the effect of a treatment that the patient enjoys, that the patient benefits from, because they believe the treatment is going to work. It reflects what the patients believe. So a lot of patients believe that injections are better, it's a more powerful treatment than giving drugs orally. Now, this may or may not be true. It depends on the medication. It depends on the patient's condition. But if you give an injection of analgesia, some people have estimated that 70% of the pain relief that the patient benefits from is from the pharmacological effect of the drug. And as much as 30% of the pain relief that the patient experiences is because they believe the injection is going to work. So if you're giving injections and the patient believes it's going to work, that's a good thing. So make your patients believe it's going to work, and they'll have a placebo effect as well as a pharmacological effect from the drug. In other words, use the placebo effect to the advantage of your patient as far as possible. However, many people like injections because they think they're better, when in actual fact it's not the right thing for them to have. So my firm belief is that as healthcare professionals, we should never give an injection which the patient doesn't need for sound clinical reasons. If a patient asks for an injection and they don't need an injection, we must not give them one. We're now going to think about the routes via which injections can be given. They may be given intradermally, subcutaneously, intramuscularly, or intravenously. And we're going to look at what that means now in terms of the tissues into which you need to deliver the drug. We don't actually give intradermal injections very often. They're sometimes used in vaccination because it means you can give a smaller dose of the vaccine. It's worth bearing in mind and checking out if you can give vaccines this way, if you ever need to give a lot of vaccination but you're short of vaccine. So this is the syringe here. This is the drug which we want to give. And this is introduced down the needle into the dermis. Now this diagram is fairly high magnification. This is the epidermis here, and you can see the wavy line between the epidermis, which is the top layer of the skin there, epidermis, and this section here, which is the dermis. So you're actually giving the drug into the dermis. And you can tell if it's working because you get a blebbing up, you get a blistering effect of the surface of the skin. This is the subcutaneous tissue here below, which we don't want to give the drug into. And normally, to ensure the drug goes into the dermis, which of course is quite a thin layer really, because this is high magnification, it's normally given at a fairly narrow angle, maybe at about 10 or 15 degrees. Quite hard to give intradermal injections. You'd have to get someone to teach you how to do it and maybe practice it with some saline before you did it, giving an actual drug. So here we see the syringe, the preparation being delivered into the subcutaneous tissue. Now this diagram is lower magnification because this top layer here, this bit here, is the epidermis and the dermis. That's the full thickness of the skin. Now below that, in most parts of the body, you have an area of adipose subcutaneous tissue. Subcutaneous just means below the skin. Maybe there's muscle underneath that, deeper than that. And the drug is normally introduced, the needle is normally introduced at an angle of about 30 degrees. Now some subcutaneous injections are actually given at an angle of 90 degrees, where it's necessary to bunch the skin up and then give it at 90 degrees. People do make a bit of a fuss about this, arguing about the angle. I don't think it matters too much as long as you give the drug into the subcutaneous tissue where it's supposed to be given. It's important not to go too shallow, so you just end up in the dermis. It's important not to go too deep, so you don't end up in a muscle beneath. Because if you end up in a muscle beneath, the drug will be absorbed much more quickly than it would be subcutaneously. So 30 degrees or 90 degrees, depending on the nature of the syringe and the preparation. The key thing is, though, in a subcutaneous injection, you deliver the drug into the subcutaneous tissues. Intramuscular injections are given using a longer needle, and it's given at 90 degrees to the surface of the skin. Here we can see the skin layer here, the epidermis and the dermis. The needle has penetrated straight through that, straight through the yellow layer, which is the subcutaneous adipose tissue, and the needle is giving the drug directly into a skeletal muscle. Here we see an arrangement for giving drugs intravenously. The syringe is normally connected up to this giving port here, and the drug goes through the cannula, which is already in place, directly into the bloodstream. Now, it's much easier if a cannula is already in place. Other times, it might be necessary to insert a needle or a cannula if one is not already in place to get the drug into the vein. Now here we see the skin, subcutaneous tissue, and this is a peripheral vein cannulated by this indwelling cannula to allow administration of intravenous drugs directly into the venous circulation. So intravenously, the drug is injected directly into the blood. Intramuscularly, it's into a skeletal muscle. Subcutaneously, it's into subcutaneous tissue. Intradermally, it goes into the dermis. And one route we haven't mentioned yet is injections can also be given locally. For example, local anaesthetics can be given to generate local analgesia using lignocaine or something like that. Sometimes injections are given directly into a joint, maybe steroids in such conditions as rheumatoid arthritis or other inflammatory joint diseases. Sometimes injections can be given directly into nerves, either to kill the nerve for chronic pain or for temporary pain relief using local anaesthetics. So the main routes that injections are given by. So first of all, let's think about giving drugs intravenously. This has the most rapid speed of action. The drug starts to work within seconds of being introduced into a vein. Drugs delivered directly into a systemic vein. It must never be delivered into an artery, it must always be a vein. It gives rapid, high plasma levels of the drug, but the drug levels do drop off more quickly if the repeat injections are not given. It's possible to give infusions as well. You can give fairly large volumes and delivered at sometimes high dilutions with intravenous infusions. And a big advantage is you can titrate the dose. Titration means that you moderate the amount of drug that you give depending on the clinical effect that you observe. So if someone's in pain, start to give them some intravenous diamorphine slowly. When the pain goes, you can stop giving the drug. That means you can give the minimum amount of drug that's required for the therapeutic effect that is desired. Intravenous injections should be painless unless there's a problem. Pain would normally indicate infection in the vein or the fact that the drug was being introduced into the tissues rather than into the vein. So as well as watching the systemic condition of the patient when you give the drug, it's very important you also look at the local site to make sure the drug is going into the vein and being carried away by the circulatory system and not just entering the tissues locally. And of course, you must be very competent to give these injections because as well as giving a rapid therapeutic effect, there's a rapid adverse effect. And that is why normally student nurses don't give intravenous injections. They normally learn to do this once they're qualified. Let's think now about intramuscular injections. Now, skeletal muscles are relatively well perfused with blood, so the absorption's fairly rapid, and the drug will start working normally about 5 or 10 minutes after the preparation has been given. So well perfused muscles means that the drug gets from the muscle into the bloodstream, into the systemic circulation fairly quickly. Because when you're giving a drug systemically, the aim is to get it into the plasma. And that happens because the muscle's fairly well perfused. And intramuscular injections, okay, they do hurt, but skeletal muscles aren't that well innervated with pain receptors. So with good technique, the discomfort is minimised. So it's a good idea because there's relatively few pain receptors in skeletal muscle. Up to 5 ml of fluid can be given via an intramuscular injection. You shouldn't normally give more than 5 ml of fluid into any one site. Because as you put in the injection, it swells in the area, the tissue goes into the area and is going to force apart tissues in the area. And more than 5 ml causes unacceptably high levels of tissue damage. If you're giving it into the muscle in the arm, into the deltoid muscle, you would normally only give 1 ml, or at absolute most 2 ml, because it's a much smaller muscle. So normally 1 ml into the deltoid. Another advantage of giving drugs intramuscularly is that some drugs are very hazardous to give intravenously. For example, if you needed to give a patient adrenaline and you give it intravenously and you give it too quickly, well, that can cause ventricular fibrillation. So in conditions such as severe allergy, like an anaphylactic type reaction, adrenaline can be given intramuscularly, in which case it's pretty safe. It's certainly a lot safer than giving it intravenously, although obviously giving any drug is associated with some degree of risk. Now in the muscle, you can give oily preparations, and this can give delayed absorption over several weeks. And this can be a major advantage if a patient is not going to comply with an oral medication regime. For example, some psychiatric patients are given antipsychotic drugs intravenously in oily preparations, intramuscular phenothiazines, and these are absorbed slowly over a period of time. So the antipsychotic medication will diffuse out of the muscle slowly over a period of time. Contraceptives can occasionally be given via a depot injection as well. Depot means you put the injection in and it comes out from the muscle slowly over days or weeks. Now, if you give a drug intramuscularly, it must say for intramuscular injection on the vial that the manufacturer produces. If you give a drug subcutaneously, it must say the same. If you give a drug intravenously, it must say the same. The drug must be specifically designed to be given via the particular route. That's why it's so important that you don't give the drug via the wrong route. So imagine you stuck your needle into a muscle. Now there are some blood vessels in muscles, so there's a possibility that you could have stuck your needle into a blood vessel. It's unlikely, but it's possible. So what you must do when you've stuck your needle in is to draw back on the syringe. Draw back. And if any blood comes out, that means you're in a blood vessel, which means you mustn't inject the drug because it's not going into a muscle, it's going into the bloodstream. And especially with oily preparations, if you inject them into the bloodstream, it's a potentially life-threatening situation. So when you've stuck the needle in, before you inject the drug, always draw back to make sure you're not in a blood vessel. If you draw back and there's no blood, carry on and give the injection. If you draw back and there is blood, the safest thing is to pull the whole lot out again, change the needle and reintroduce the injection. Draw back, then you'll probably find you're not in a blood vessel. Very rarely that you are in a blood vessel. But it's so important that every time you stick a needle in, you draw back, make sure you're not in a blood vessel before you give the preparation. If you are giving an intramuscular injection, you must be in a position to guarantee that the drug is in fact going into a muscle and not going into some other tissue, for example, the blood. What I'm doing now is simulating the situation. And here you would imagine that you've stuck the needle into the muscle, and before you inject the drug, you always draw back to make sure you're not in a vein. So I draw back on the syringe. Oh, here blood has come out from a vein, meaning I'm in a blood vessel. So I would take the syringe out, change the needle, try again on another site, because if I injected, the drug would have gone into a vein and not into a muscle. Another principle whenever you give injections is that you must never ever introduce air into the body. This is absolutely vital if you're giving an intravenous injection, and it's important with any injection. And here, unfortunately, as I've drawn up the drug, some air has been introduced into the syringe. I must not allow this air to enter the body. I therefore simply turn this upside down, and to stop this bit that's in here getting blown out, first I'll draw back like that. You can see that drips through, and then I'll expel the air. I'm expelling the air, and I'm just watching the meniscus rise up the syringe there, and I can hopefully stop there before I squirt and lose any of the drug. That's now ready to be introduced into the muscle or wherever you're giving the injection, and all that will go in is the liquid of the drug, which would normally be clear, by the way, but the liquid of the drug, and no air is being introduced into any body spaces. Intramuscular injections, fairly good absorption from well-perfused muscles, relatively few pain receptors. Of course, it's very important to make sure the muscle is relaxed. The muscle is tense when you inject and stick the needle into it. That will be very painful. Up to 5 mils in the leg and the buttock, in the gluteal muscle. Maybe only 1 mil for a deltoid, 2 at the absolute maximum. Good idea for drugs that are hazardous to give intravenously, such as adrenaline. Delayed rate of absorption may be an advantage for depot injections, such as antipsychotics or contraceptions. Some intramuscular preparations may cause embolic complications if given intravenously, so always draw back. Whatever the drug, always draw back. Make sure you're not in a blood vessel before you introduce the drug.